Hi and welcome to this tutorial. My name is Naomi Hammond.
And I'm Coleman Taylor, and we're working closely with Professor John Myberg and Professor Simon Finfer on a new fluid resuscitation translational study. We'd like to take you through the timeline of key fluid resuscitation research leading to the development of this new and exciting study, and we really hope you'll be interested in participating.
So I'd like to start with the SAFE study, which was published in 2004. The SAFE study was conducted in response to the 98 Cochrane Review showing elevated risk of mortality with the use of albumin. So the SAFE study enrolled close to 7,000 general ICU patients and looked at the primary outcome of 28-day mortality. The results showed there was no difference between being resuscitated with albumin or saline on 28-day mortality. And so to understand the impact the SAFE study had on international clinical practice, we devised a study examining fluid resuscitation practices globally called SAFE TRIPS.
So SAFE TRIPS was a cross-sectional poor and prevalent study conducted in 25 countries and 391 ICUs. As you can see from the graph, the results showed wide variation in practice between countries, and when we looked specifically at colloids, starch was one of the most popular choices in many countries, particularly 130/0.4 hydroxyethyl starch.
So another important finding from the SAFE study were the traumatic brain injury and severe sepsis subgroup analyses, which showed diverging trends in mortality associated with the use of albumin. So these studies were published post-SAFE TRIPS and form part of the current context to re-evaluate fluid resuscitation practices in the proposed study.
So in 2008, VICEP was published, adding another key study to the fluid resuscitation debate. VICEP enrolled 537 patients and was stopped early for safety reasons. The study compared ICU patients resuscitated with Ringer's lactate and an earlier preparation of hydroxyethyl starch. And results showed an elevated risk of mortality associated with hydroxyethyl starch use, and this effect was found to be dose-dependent, as shown in the bottom graph.
So in 2010, a scandal developed in fluid resuscitation research when the validity of published research findings were questioned. The researcher Joachim Bolt, a German anaesthetist, was found to have published fraudulent findings in relation to hydroxyethyl starch. So Dr. Bolt's research was the main body of work underpinning the benefits of hydroxyethyl starch use as a resuscitation fluid, and the scandal emerged in the middle of the CHESS study recruitment.
So the CHESS study, along with the Scandinavian 6S study, were designed to answer key questions regarding the safety and efficacy of hydroxyethyl starch in comparison to crystalloid preparations. The 6S study was undertaken in Scandinavian ICUs and randomized approximately 800 septic patients to receive 130/0.42 hydroxyethyl starch or Ringer's acetate. CHESS was undertaken in 7,000 general ICU patients in Australia and New Zealand, and patients were randomized to 130/0.4 hydroxyethyl starch or 0.9% saline. The results of 6S demonstrated that 130/0.42 hydroxyethyl starch was associated with lower survival compared to Ringer's acetate at 90 days. And for the CHESS study, results showed no difference in survival over 90 days in the general ICU population. However, patients resuscitated with hydroxyethyl starch had a higher risk of requiring renal replacement therapy compared to patients receiving saline.
So, in summary, SAFE TRIPS showed region is one of the strongest predictors of fluid choice globally. And since SAFE TRIPS, there's been several high-profile studies which have questioned the use of colloids, particularly hydroxyethyl starch. So we believe there is context to re-examine fluid resuscitation practices globally using a similar methodology to SAFE TRIPS, and this is called fluid TRIPS.
So fluid TRIPS aims to describe international trends in the prescription of fluid resuscitation and to determine factors associated with fluid choice. The key characteristics of the study are that it's cross-sectional, point prevalent study design using a 24-hour chart period at each participating site. Sites will only need to participate on one of the study days and will utilise a convenient sampling among the regions in order to capture representative samples of most of the regions globally.
So the types of patients we are looking for are adult patients that are 16 years or older that are present in the ICU at the start of the study day or admitted during the 24-hour study period, which will be included in the sample. So the data collection will be restricted to patients receiving fluid resuscitation only, and fluid resuscitation is defined as a bolus of crystalloid a crystalloid infusion of 5 mL per kilo per hour or greater for 1 or more hours, a colloid bolus, or any colloid infusion.
So the primary outcome from fluid trips is to describe the amount and type of fluid resuscitation currently administered to adult ICU patients in different countries around the world. We'll also compare the results to safe trips to examine changes in the prescription of fluid resuscitation preparations globally. A secondary outcome is to describe and compare the cost of fluid choice between different geographic regions.
So if you haven't joined us and you are interested in participating in fluid trips, please email Maryam, who's the project manager, through the email on the screen. If you're already participating, we thank you for your support and look forward to working with you.